My name is Dr. Kamalendu Malaker. I'm a professor of clinical oncology, and I've been working as an oncologist for nearly 50 years. I started my training in Oxford and at the Royal Postgraduate Medical School in London, and then I worked there in the Hammersmith Hospital, and then Cancer Care in Manitoba, then the Harvard Medical School, and then many other places I've worked in a very senior position. So standard protocol is primary surgery followed by adjuvant radiotherapy. Nowadays, what we use, then neoadjuvant chemotherapy. But we're suggesting that before primary surgery, we should think about adjuvant radiotherapy or chemotherapy or immunotherapy, or think of neoadjuvant chemotherapy, a single drug, followed by surgery and chemoradiation. The neoadjuvant, the various ways of the standard protocol of practice, how surgery is mixed, combined with other modalities. But what my thinking is, so we found out that neoadjuvant chemotherapy, when you give with radiotherapy alone, we gain with chemotherapy and hyperthermia, we gain about 1.2 with hyperthermia. Again, with hyperthermia, when the concurrent chemotherapy, neoadjuvant concurrent chemotherapy, radiotherapy, with multiple combinations, the gain factor is 1.4, 40% increase. And when we give this above 2 plus surgery, then we get up to double. It becomes 100% with hyperthermia. We get 100% advantage. When you use standard way of treating chemotherapy, standard of giving adjuvant radiation chemotherapy with added hyperthermia, from 1.2 only hyperthermia to combined chemotherapy, multiple chemotherapy, radiation, and hyperthermia, we can actually double the gain factor when used in a combination way. So this is the algorithm. With the cancer, we give neoadjuvant chemotherapy, or then only one or two cycles. Then we do the surgery. If surgery is not done, then we give concurrent chemoradiation with surgery, concurrent chemoradiation, 1 or 2 or 3 cycles. Then you go for surgery. And then after that, we give, if necessary, with surgery, give hypothermia is a part of every course of treatment, with surgery, pre-op and post-op, adjuvant treatment, pre-op, post-op adjuvant radiation, and post-op with concurrent chemoradiation and concurrent chemoradiation. When we're giving concurrent chemo, with every concurrent cycle, we give hypothermia at least once. And it is so post-op same thing. Whether it's concurrent chemo or adjuvant, we give hypothermia. The advantage is we need to give only one exposure of hypothermia as opposed to 5 exposure of radiation, or even continuous chemotherapy. We don't, unlike radiation, with only once every week, we give the best benefit or optimal benefit, or maximum two exposure of hypothermia to get the best benefit. No more. Thanks. So this is the protocol, augmented. How we go. Give neoadjuvant, then we, if necessary, give preoperative chemoradiation, then go for surgery, but there is hypothermia before and after surgery. Then we post-operative adjuvant radiation, then give hypothermia, post and pre and post, and then concurrent chemoradiation if we have to give afterwards. And then we just, during the follow-up, that is the end. And we just follow up the patient. This is how we can augment the effect of standard radiotherapy with a different way of giving and administering the drugs and the radiation and giving the surgery for the best benefit. As I said, we can increase the uh, gain factor almost 100% if we follow this protocol. This is what we call innovative recycling. It's not really recycling; it's re-engaging the drugs. So anyway, this is now we're talking about the mathematics or the things. Do you still want to go through the facilities, the logistics, or we want to stop? I'll talk about here. You can separate it another talk, another lecture. This is infrastructure. How much it costs? A cobalt treatment costs only 80, just about 800,000. Hyperthermia unit costs 1.2 million. Kilovoltage costs 250,000. So this is what it will cost to establish the hyperthermia treatment unit. And we need the treatment planning, 400,000, chemotherapy setup, 100,000, and procedure room, 250,000. The building itself with bunker, radiation, all those things will cost about 2 to 4 million USD, and the other structural components about 1 million. This is the infrastructure which will cost to establish a hyperthermia plus other treatment unit to establish, to start from zero, from ground level. So this is the size of the treatment area. We need 1,500 square meter if we're using cobalt treatment facility, cobalt and hyperthermia and chemotherapy. And then what other things we need is an oncologist, their salaries, technologists, their salaries, nursing, their salaries, physicists, junior physicists, engineers, secretarial and program coordinator. These are the staffing need to start a hyperthermia adjuvant to standard classical radiotherapy unit. But this is nothing more. This is not anything extra. This is what we need to have the proper comprehensive cancer therapy unit, which includes radiotherapy, chemotherapy, and of course surgery is the part of the hospital treatment anyway. So the telecobalt, these are costs between telecobalt and linear accelerator. Linear accelerator costs 4.5 million. Telecobalt is just about 800. It is coming even lower, 1,000. Linear accelerator can be between 6 to 20 million volt, but telecobalt is 1.7 to 2 million volt. And that is where hyperthermia comes at a big advantage. Maintenance is high. Why maintenance? It has to be checked every day. Every day. A physicist must check every day before we switch it on. Telecobalt is also need to check, but the checking is minimal. You can work at linear accelerator only for 8 hours, but telecobalt can go for 12 to 16 hours. At times, we used when we're too much pressed, up to 18 hours when they need to do it. The longevity for a linear accelerator is 10 years, and after 10 years we have to change. And now it is the company tells you that after 10 years you should not be using it. But telecobalt can go on and on for 15 years, providing you change the radioactive source. It lasts for 5 years, 5 to 6, even now 7 years. To maintain the linear accelerator, we need highly skilled staff. But for a telecobalt, we don't need that much. We need skilled staff, no doubt, but we need medium, the ones who can handle the technology reasonably well. But we need the treatment unit is same. We need MLC, we need HEMAT, CXGRT. All these things used to be only used for linear accelerator, but nowadays we know that we can use this IMRT, MLC, DMAT, SGRT, all these things, all these very specific focused treatment can be used for telecobalt unit. Those technologies are available and they're used in many places, I know. Particularly a very well-known institute, Royal Marsden, where they started the usage of telecobalt units, of using this high-mark TMLC and HEMAT and SDRT using telecover. The advantage is that even in very poor countries where they can have telecovert unit for treatment, they can use these very interesting, focused technical procedures for treatment of cancer when they get less toxicity and higher tumor control rate. So, for a telecovert unit, we need 1200 meters square, plus hyperthermia is 300 meters square. For linear actuator, we need a 1500 meters square and 300 for hyperthermia. If you combine a center with telecovert, so we need a smaller area to establish a treatment unit, including radiotherapy and hyperthermia, when we are using telecovert unit. The rationale for innovative recycling is telecovert units for external beam radiotherapy. The reason is simple. It is low maintenance, low technology, and it is cheaper, and it can be used in many places, even where? In Chittagong, in Bangladesh. Anyway, and it can be used for neoadjuvant treatment plans, and it can be used, if it is judiciously used, it can be used as a multiple combination with chemotherapy, with shorter chemotherapy, and instead of 2 and 3 weeks with the chemotherapy, and then with reduced number of radiotherapy treatment. Nowadays it is established that we can get almost similar benefit by using only 10 to 15 treatments instead of 25 to 40 treatments. But more centers are using 25 to 40 treatments, but there's no reason, but there's enough evidence that 10 to 15 treatments with slightly higher doses per fraction will do the same job as 25 to 40 treatments. Same therapeutic benefit. And then, along with the programmed use of hypothermia, as I showed in the algorithm, from start to end of the course, that will enhance the treatment significantly. So, the cost of treatment, composite treatment reduction from a telecovert-based combination unit is anything between 3,500 to 5,000 USD, and some places, particularly in India, is as low as 1,000 USD. But similar treatment in developed countries, anywhere, is between 10,000. Even some places where I work, they're supposed to be developing countries, the minimum treatment cost is 10,000. And it can go up to 400,000. But we use proton beam, which has become a love of radiation oncologists everywhere. It costs anything from $500,000 to $1 million. So, where do we go? We have no way, we cannot go up and up and up. I have nothing against proton, is a wonderful technology. It has got excellent biology, what we're still learning, the real biology of proton beam, but still it does its job. It does kill cancer, it does have huge therapeutic benefit, less toxicity, but the cost is absolutely prohibitive to 90% of world population. So then we go to logistics of operational requirement. What do we need to do it? We need the land, we need the building for parking, gone, land, we need building for parking, we need equipment, we need staff, we need logistics, and we need diagnostics, we need imaging, and we need operational manuals like APP, IPP, all those things. So this is one option. The first option, when you're starting from scratch, we need to start from land, building for parking, we need equipment, all the equipment, we need all the staff, we need logistics, diagnostics, we need the imaging, as I mentioned before, and the whole program, operation, develop APP, IPPs, and all this organizational aspect. But option two is, if you get the land is provided by the government or some kind person, then that cost is reduced significantly. The land cost is huge. That's option two. So if you're trying to develop a comprehensive hypothermia and low cost oncology center, try to find out if you can get the land free, provided before we plan. The option three is the building. We have the land and we already have a building where we can establish the unit. And how we can do it, that will either we have an already obsolete building which you can work on, or I have used that way and one whole psychiatric hospital changing the oncology center. So it is possible to find out locations where you can use the building to establish a oncology center where the possible is there. You can build a bunker, you can bring the chemotherapy sets, you can bring the ward, and all those things can be used in an old building which is not being used. Next, option 4 is the land of the building, and if we can get access, that's option 4. With the land, the building, then here, if we can gain access to already operational cancer center, which has equipment by radiation therapy equipment, the planning system, simulation, and the physics equipment, then we can latch onto it and we can really use that equipment. And with only moderate extension, what you have to do is to establish a hypothermia unit. And that doesn't take much space, it does not take much expertise. All you need extension and people interested to do it. And the people are very easily trainable to apply hypothermia in conjunction of the whole protocol. Option 5, this is what it is. Now, if we can get an already functioning oncology setup, there, and we just add this hypothermia unit as an extra service. If I work in many places where we don't need to build an extra room. We can use an extra patient's room or extra waiting room to house the hypothermia unit and start to develop the program pertaining to existing functional oncology setup. The people, those who are delivering radiation oncology, radiotherapy technologies and fields, they're very easily trainable, really, to deliver. So we can either train them or recruit only one person who is trained to deliver hypothermia, and then they can train the others. So the option 5, when we can add hypothermia with a functioning oncology center, then just only services for hypothermia unit. Again, we don't need an extra building, extra room. We can use one of the rooms, and then for staffing is minimal. Just train only one person, one technologist, and then they can train other technologists, those who are currently giving radiotherapy to patients. And same thing, we are doing planning also. Option 6, again, functional unit. When we take cobalt or Linux, which is close proximity to tertiary care hospital, and we extend the unit or accommodate hypothermia unit, and we should develop an independent program for hypothermia, how to inject or interject hypothermia as per my algorithm for other established treatment, or create an integrated program with existing oncology and a consultative and supporting service. So you don't need much. If we can utilize the existing functional oncology unit, whether it has got a cobalt or lilac doesn't matter. Cobalt is just as good. And this is the least expensive and most comprehensive, and this is the ideal way at this point in time to establish or use the huge benefit of hypothermia incorporating in oncology for treatment of cancer, for treatment of how to function North American business model, how to finance either rent the property, lease the equipment, you can contract the service. Some of them are tenured, and you can use overall clinical managerial supervision. So these are all business model what you can use to start an oncology. It works in North America, but I'm not sure it is ideal for the rest of the world, to be true. And it does quite well in North American system. But this is can be challenging, but it is one way already an established way of delivering cancer treatment. The option 7, 8, and 9. Any of these, one or two, or all of them together.